As we know, the pandemic, with the pandemic, one of the keys to sort of seeing patients safely in person is really to reduce the volume of people in our waiting rooms for social distancing, and really reduce the individual wait times for each person that does come into clinic. People are much more comfortable if they know they're going to be able to come in and leave very quickly, as opposed to waiting around in a crowded waiting room. So this really required us to look at how to reduce that daily clinic volume, but still provide quality care to all of the patients that really, need to be seen in a timely manner. So now part of my time consists of identifying in advance those patients that might be good candidates for either a purely virtual visit or a hybrid visit, which was where a patient would come in for basic testing by the ophthalmic technician and some additional glaucoma or retina tests, and then followed by a separate telemedicine visit with me to review the results. And once those patients are identified, my office will call them and offer them that opportunity to do these either virtual or hybrid visits. So now on a routine in-person clinic day, my clinical volume has been reduced to about 60 to 70% of my prior volume. But at the same time that I'm seeing patients in clinic, I'll also have my patients come in, do their testing, and then leave without seeing me to be followed up upon on a different date. So for me personally, I prefer my telemed specific clinic to be on a separate date where I can just kind of sit down and do a number of virtual visits all at the same time. I do have colleagues that prefer their telemed visits sort of interspersed throughout their in-person clinic times, and it really is a personal preference. And overall, I think that patients have been very happy with this. The patients that do come in are very appreciative of the fact that our waiting rooms are not so crowded, that they're seen in a very timely manner. And the patients that do have the hybrid or the virtual visits are very appreciative of the fact that they're getting their care without even having to come in.
It was pretty amazing because we had the infrastructure in place. On Friday, March 13th, I did like 2 virtual visits. And on Monday and Tuesday, March 16th and 17th, I went up to 15, 20, 30 a day, and just kind of flipped that switch, which was really nice to see. But essentially what Peggy just talked about and what Dr. Friedman just alluded to a little while ago with the hybrid visits and the testing, some of this stuff we were already doing, but not as well, because we didn't really focus on telemedicine and virtual visits. It was a nice addition. Patients loved it. Us clinicians that were doing it loved it, but it wasn't a necessity. And with the necessity comes the innovation and the willingness to adapt with some of the learning and technical difficulties that you're going to experience when you start. And so now the way it's evolved is across the system as a whole, we are doing somewhere between 1,200 and 1,500 virtual visits per day, which is pretty awesome. Now, obviously, that's not all in ophthalmology. A field such as neurology, for example, is at about 95 to 105%, depending on the day, virtual visit volume compared to what they were doing in clinics. And I think a place like ophthalmology, at least at the height of the pandemic, was at 80, 90% virtual, but then has now reverted back with these hybrid visits and with purely like in-person visits for those that need testing, so that our virtual visit volume is now down to maybe 15 to 30%, depending on the day. And so I think there's going to be this shift, this ebb and flow over time, and I think we need to see where we're going to settle out. But I think with time, with more technology, we're going to develop innovations on how to do this better, how to make more things hybrid, some things completely virtual, and then some things are just going to require us to have the patient come into the office. But now we have the space and the efficiency to do that. And I think the cost to the system will go down with time because we'll be more focused on what we need to do for those patients as opposed to doing extra stuff that may not be relevant.
So I got my master's in public health from 2013 to 14. And during that time, I got to spend some time in the Middle East and worked with refugees. Now, when I was doing this, some of those individuals came down with eye trauma, and they couldn't get eye care where they were. It was hard to get eye doctors to them. It's hard to get them to the eye doctor. And I thought that in today's day and age, with technology as advanced as it is, it should really be possible to get the patients the care they need whenever they need it. So now, with that in mind, I go through residency, have this in the back burner, bring it up as an idea, And now I'm doing an entire year dedicated to telemedicine research, innovation, and I have some amazing mentors, both of which are on the call, Alice Lorch and David Friedman. So the whole institution's kind of come to bear and trying to make this a reality, which is awesome. And it also it's worth mentioning that I came up with this idea along with people at Mass Eye and Ear well before the COVID pandemic. And so this was already in the works before everything hit the fan. So as far as what my day-to-day is, I do see patients 2 days a week in person, and we're setting up telemedical models to help employ within that system. And then the rest of my time is spent doing research, setting up practical hands-on telemedicine for patients across the Mass Eye and Ear and the Harvard network, and kind of engaging in all that could be. One of the aspects of this that's interesting also is that I'm also helping with a startup here in the Boston area that is working on telemedical devices for the ophthalmology space. And so the Mass Eye and Ear Institution is also helpful and supportive in that regard. We may get some clinical trials running at our institution to try to get those things off the ground. So within our ecosystem, we have a lot to bear. So we have not only Mass Eye and Ear for its amazing ophthalmic care and Harvard Medical School with all of its resources, but we have MIT across the river, where we have two of my co-founders coming from. We have Harvard School of Public Health, which is actually what came up with this idea in the first place. We have Harvard Business School, where people smarter than me are trying to make these things a reality on the business front. We have, you know, a crazy amount of resources at our fingertips to make these dreams a reality.